next Dr. Shyam Agarwal, who's another cancer specialist, another clinician who will be talking, medical oncologist with more than 3 decades of clinical experience, another senior consultant from Sir Gangaram Hospital, New Delhi, who has done his MBBS from Chandigarh and then MD medicine from PGI Rohtak, after which he has done special training from AIMS, New Delhi. With special interest in bone marrow transplant, he's undergone training at University of California, Los Angeles, and St. Vincent Hospital, Sydney, and is a renowned oncologist, honored with many awards and recognitions in his illustrious career. So I think I'll not waste more time and will request Dr. Shyam Agarwal to continue with the talk, please. Dr. Shyam.
So thank you, Dr. Ashwini, and thank you, Dr. Sunila, for this opportunity and invitation. So I think whatever I'm going to say has already been said by so many speakers. So it's kind of a summary as to trying to put things into perspective because today, as Dr. Rajiv said, so we are in the era of personalized medicine. So I think I'm basically going to sum up the whole breast cancer scenario into 6 subtypes. So can I have the next slide? So on the basis of initial investigations, patients can be divided into HR positive, which is hormone receptor positive. So you can have HR positive, HER2 positive, and triple negative breast cancer. So those are the 3 subtypes which you need to identify today at this point in time to figure out what is to be done with the patient with breast cancer. And this has already been said by the earlier pathologists that you need to have ER negativity and ER low positive and ER positive defined on the basis of all-red score and other parameters in the morphology and the histopathology. So as I said, 6 subtypes: HR positive, early breast cancer. I think I'm just going to talk of new things which were again referred to before. Ki-67 more than 20% is becoming very important because the pathologists from Tata said 20%, 30%, we're not sure. But the US FDA and the NCCN guidelines are allowing us to use abemaciclib in the adjuvant setting along with the hormonal therapy for patients who have Ki-67 more than 20%. So I think the pathologists have a very important role to tell us the Ki-67 on the tumor specimen. This was again addressed. Genomic tests are important and we are doing them routinely. The samples are being sent abroad for Oncotype DX, mainly for node negative or up to 3 nodes positive to decide whether a patient could get away without chemotherapy. Then BRCA1-2 test is also being done in early breast cancer because the Olympia trial allows us to use olaparib, especially in high-risk cases. So, you really need to identify these 3 important parameters to decide which drug the patient needs in the adjuvant setting in patients with early breast cancer. I think these are the guidelines. They are available in the NCCN for the Oncotype DX. Dr. Rajiv gave a couple of examples on the pre-menopausal or post-menopausal. Depending upon the score, one needs to figure out whether the patient can avoid chemotherapy in the adjuvant setting. So now coming to the advanced breast cancer scenario, CDK4/6 inhibitors are readily available because along with the aromatase inhibition, most of the patients are subjected to CDK4/6 inhibitors. So you don't need to do any test for that except for ER positivity. So in the second line, as was pointed out, we need to know whether the PIK3 is positive or negative, the mutation is there or not there. One can do it on the old specimen or even in the new biopsy. And if it is positive, then the patients can be subjected to alpelisib along with fulvestrant after the failure of CDK4/6 inhibitor. And similarly, in the third line or sometimes even in the second line, BRCA1-2 also needs to be tested in these patients and PARP inhibitors can be used. So this is a research area where new mechanisms of resistance are being identified by next generation sequencing on ctDNA, like ESR1 mutations. There are new SERD inhibitors, which are going to be launched soon in all over the world. HER2 new mutations, if found in patients with HR positive, means hormone receptor positive, these patients can then be treated with HER2 new drugs, which I'll just refer to. FGF mutations are also responsible for resistance in the hormone sensitive population. So, this is an area of research, but I think we can do this with the ctDNA NGS. Okay, so now coming to the HER2 positive, this was quite, eloquently informed and told by the speakers before. So not only the FISH test, but the positivity and the ratio of HER2 versus CEP17 and the HER2 copy number can help you decide which patient is HER2 positive, because it is very important because we have these drugs which can really change the scenario. So I think this was again referred to briefly. If the tumor size is 2 centimeters or more and it is early breast cancer, then patients should be subjected to neoadjuvant therapy. And what is the importance of neoadjuvant therapy lies here. If there is PCR, then you can continue with the same treatment which you were giving before. But if there is residual disease after the neoadjuvant chemotherapy and surgery, then TDM1 is to be changed. So you can tailor your therapy, and therefore, even in a small tumor, which is 2 centimeter or 3 centimeter HER2 positive, neoadjuvant chemotherapy with HER2 targeting is become important. So what about metastatic breast cancer? I think currently we have only 4 drugs available in India, but I think abroad there is a lot of new work which is now available, new medicines which are available. In first line, in the metastatic disease, we are using trastuzumab, pertuzumab, and chemo. Second line, we have this antibody drug conjugate called TDM1. And in India, we have the cheaper version of HER2 new drug called lapatinib. But I think these new drugs like trastuzumab, deruxtecan, and tucatinib, they are so critical and so impressive that it crossed the blood-brain barrier, and they have actually moved after the first line failure in America and in Europe. But unfortunately, we don't have access to these drugs. And there's a very important aspect, which I think the pathologists also must know, that these new drugs like deruxtecan, they not only work in HER2 positive cases, but HER2 new low cases. So when a patient is HER2 new 1 plus or 2 plus and FISH is negative, but they're labeled as HER2 new plus. So this is a new category of patients where trastuzumab deruxtecan has shown very promising results, not only in breast cancer, but also in lung cancer, colon cancer, and stomach cancer. These are the other 2 drugs which are not available, margetuximab and neratinib. So, so there is a plethora of HER2 new targeted drugs which are now becoming available across the globe. We don't understand much about the mechanism of resistance, but that needs research. And this is the final set of patients. TNBC in early breast cancer, like in HER2 new positive breast cancer, again, there is a role for neoadjuvant chemotherapy, and there is a role for BRCA1/2 testing, because that could help us decide what kind of surgery we want to do in a BRCA1/2 patient. Is there a role for contralateral mastectomy, because these patients are prone to getting cancers in the opposite breast. In role of immune checkpoint inhibitors is also established, especially in the US, and there's no role for PD-L1 testing in giving immune checkpoint inhibitors in early breast cancer along with chemo. But then these drugs are available, and I think people are using these checkpoint inhibitors. But in early breast cancer, no role for PD-L1 testing. So as I think Dr. Rajiv showed, if there is residual tumor after neoadjuvant chemo and surgery, post-surgery treatment in the form of capecitabine can be given for another 6 months. So I think suffice it to say that in TNBC and in HER2 new positive breast cancer, early breast cancer tumors which are less than 5 centimeters even, or even 2 centimeters, 2.5 centimeters, the role of neoadjuvant chemotherapy is getting established, and surgery role is not going away anywhere, but then it is relegated to after 6 months of or 6 cycles of chemotherapy. So what about TNBC? PD-L1 testing needs to be done, as was shown before. to decide the immune checkpoint inhibitors, especially for pembrolizumab. CPS score should be more than 10. I think it is imperative on the part of pathologists to sort of now learn this CPS scoring and the PDL testing for various techniques and various antibodies, Ventana, Deco, etc. So I think this has become so very important, not only in breast cancer, but another variety of so many cancers. So I think BRCA1-2 testing is important. Whether it is germline is more critical. I think there is data evolving and emerging for somatic BRCA1-2 testing because of the role of PARP inhibitors like olaparib or rucaparib and even talazoparib. I think we also do androgen receptor testing for TNBC patients because these patients can then be prescribed a drug like enzalutamide. Comprehensive gene profiling, I'll just cover in the next 1 or 2 slides. So this is to sum up, the targetable pathways in breast cancer. As you can see, the ERB-B pathway, which is the HER2/neu pathway, is important because you can use trastuzumab. If the patients develop resistance to AI, then the ESR1 mutation can be figured out by the comprehensive genome profiling. The HR deficient, which is the HRD cases, they become, candidates for olaparib with the BRCA1-2 testing. The IO sensitivity, which is the immune oncology or immune checkpoint inhibitors, can be judged by the PDL1 testing or by the CPS score system. PIK3, the patients become eligible for alpelisib. FGFR pathway, we have a couple of drugs. CDK pathway, we don't test. We use these immune checkpoint inhibitors today. Then the other kinase, you have these drugs. So I think a word about liquid biopsy, which was spoken to about by Dr. Tupti. I think this is still in infancy, at least in our country. We are not doing this routinely, although one can do longitudinal tracking. One can do the NGS for ctDNA, PIK3C, and so many other genes. But unfortunately, at this point in time, India is lagging behind and the Western world is far, far ahead. I was only told today that one of the labs in the next few months or 2 months' time is going to come out with a fresh liquid biopsy, which will not only look at the DNA, but also fusions and certain other genes. So I think we look forward to a successful liquid biopsy testing where specificity is very, very important as compared to sensitivity. And you can see here in this cartoon, one can look at ESR1, P53, PIK3C, and so on. If you have a good liquid biopsy, testing validation done. So I think this is perhaps the last slide, which can tell you about the survival rates for a variety of patients with TNBC. So I think I come to the end of my talk here, and I'm grateful to Dr. Sunila for inviting me to deliver this talk. Thank you very much.
Thank you, Dr. Shyam Agarwal. That was a wonderful summary of the entire disease treatment protocol followed.